Salvage of a mal-deployed partially covered metal stent after a challenging US-guided hepaticogastrostomy. A 64-year-old female with metastatic carcinoma of head of pancreas presented with recurrent biliary obstruction and symptomatic duodenal obstruction. She had history of ERCP done twice in past with two self-expanding metal stents in place, both being repeatedly obstructed. Her total leukocyte count was raised with total bilirubin of 16.5 and alkaline phosphatase of 857. Her CT scan abdomen showed grossly dilated biliary system with presence of omental deposit and segment 5 liver metastasis. Previously placed two ERCP guided stents were seen blocked in CBD. Endoscopy guided duodenal uncovered metal stent was placed first, followed by EUS guided hepaticogastrostomy. A 9 cm uncovered duodenal metal stent was placed and position was confirmed. Left lobe of liver was evaluated from proximal stomach, which showed dilated segment 2 and segment 3 ducts. However, due to intervening blood vessels, suitable window was found in segment 2 for hepaticogastrostomy. 19 gauge FNA needle was punctured, bile was aspirated and cholangiogram was taken. Fluoroscopy shows awkward scope position. Guide wire was passed deep into CBD. Fistula was created using a 6 French cystotome. Mild perihepatic fluid could be seen while passing the cystotome. Then a 10 cm into 10 mm partially covered in ratio of 30:70 metal stent was passed over the wire. Proximal part of stent could be deployed under fluoroscopy guidance. However, due to EUS scope position obscuring the view of distal radio-opaque marker of stent catheter on fluoroscopy, the deployment of gastric part of stent was blind. It resulted in intraperitoneal deployment of stent, leaving a perforation with guide wire in stomach. To salvage this, second partially covered stent catheter was passed over the wire, but due to unstable scope position and acute angulation at the gastric site of puncture, catheter and wire was repeatedly looping. After a lot of struggle, catheter could be passed inside the first stent. Careful deployment of uncovered part of second stent inside covered part of first stent was ensured under fluoroscopy. Intrachannel deployment followed by release of gastric part of the second stent was done with free flow of bile seen in stomach. Soft diet was started the next day. There was no pain, no vomiting or fever. CT abdomen was done after 5 days, which showed both the hepaticogastrostomy stent and the duodenal stent patent and in proper position with no evidence of bile leak. The bilirubin gradually decreased and she was able to start her chemotherapy. Presence of perihepatic fluid, grossly dilated biliary system and awkward scope position obscuring the radio-opaque marker view on fluoroscopy were predisposing factor for mal-deployment of stent in our case. Mal-deployed HGS stent can be salvaged if wire is deeply placed and it remains in position after stent release. Passing a second stent over an existing wire can be extremely challenging. Correct positioning of second stent is crucial to prevent bile leak. Thank you.